So I'll go ahead and introduce our first speaker. Dr. Tonja Woods is a certified geriatric pharmacist. She completed her Doctor of Pharmacy degree at the University of Wyoming. She is a clinical associate professor at the UW School of Pharmacy, as well as the associate dean for the College of Health Science and the School of Pharmacy. And she's a wonderful friend of the Center on Aging, and we always appreciate when she takes some time to come and educate us and really enlighten us on a number of issues.
So I felt like in terms of the day, it would be nice to talk a little bit about the basics of dementia, what makes it different than normal aging, and then we'll talk about the treatment and the management and so on. That's more my specialty in terms of my background in pharmacy, but I do think it's important that we kind of lay a foundation at first. So what is dementia? Dementia is a general term that we use for cognitive impairment or cognitive decline. It's a general umbrella term. We have lots of different types of dementia, and probably the most common that we talk about is Alzheimer's. Up to 70% of people who develop dementia do develop dementia in the type of Alzheimer's. So that's what we'll focus on today, but I did want to mention some other types that are out there as well. As I've commented here, it is a loss of motor, emotional, and social functioning. So it's not exclusive to one type of functioning necessarily. In some people, you will see that they have a sort of an affinity toward one or the other. They will have a more difficult time with motor functioning or a more difficult time with social functioning, but definitely can and typically does affect all types of functioning, at least by later stages. It's a slow progression, and I think that's a really important point to bring up because sometimes we'll see, especially in our loved ones, we might see a rapid change, a quick decline, and think, oh my goodness, we have an Alzheimer's situation going on here. And typically that's not the case. That's more of a delirium. If there's a rapid change, we kind of think of that more as an acute delirium, and that might be related to more of another medical problem going on or a medication in place that's not agreeing, so to speak, with the patient. And so generally, if it is a true dementia, it's a slow decline. And yes, there are things we can pick up on, but it takes a while sometimes to pick up on those things. And another key piece is that dementia will eventually interfere with ADLs. And ADLs are defined as activities of daily living. And I've made a little table here for you to kind of have an idea of what those things are. The simple activities of daily livings are just the things we did today to get here. Bathing, dressing, grooming. We got out of bed, we walked, we might have eaten a little bit, we used the toilet. Some more complex activities of daily living that we might have also done a little bit of before we came here today, or certainly are on our agenda at some point in the next few days. Using the telephone, shopping, cleaning up around the house, using the television or radio, those more complex tasks where you have to do a handful of things to accomplish getting that done. Let's see. Now I've done something here. Automatic restart scheduled. I think I'll delay that. All right. So then the question is it dementia? And I have alluded to this a couple of moments ago, but we do have changes that happen in our bodies over time, just as a natural part of aging. And that's a big concern that comes to people in terms of, oh my, am I developing some early signs of dementia, or is this just part of my age? And I have patients that come to me in my clinical practice with these questions, and sometimes it's the spouse or another loved one or a child that introduces that question. And it's actually an excellent question to ask. It's nice that we can sit down and just have good conversation about what are some of the changes that you're noticing, and we can do some assessments and sort of establish a baseline. And then if there is a problem, we can get them to someone that has a lot more sort of training in the area that can do more neuropsych testing and so on. But just some basic assessments I do quite a bit of in my clinic. So age-related changes, forgetting which day it is and remembering later, well, I do that. And I'm, just sort of, well, I guess I'll admit, entered my 4th decade. Sometimes forgetting which word to use. Again, those are natural changes in our life. We all forget to do those things. We'll pick one word when we meant another. Forgetting someone's name, I'm classic at that. I'll remember your face well, but I will have a difficult time with your name. Losing things from time to time. Every day it's a battle. Where are the car keys? Where are the sunglasses? Or where is the cell phone, etc. Forgetting to pay a bill occasionally. Now that's a little bit different than I don't ever remember to pay my bills. I didn't even know I had bills to pay. I got an odd bill that I'm not used to having in my monthly bills, and it just sat in the drawer. I let it slip. That's a natural human tendency. Some changes of concern. Having a difficult time planning, organizing. This is what we call executive functioning, and this is definitely something that we see people lose in terms of progressive dementia. And this might be something like planning a birthday party for your loved one, and you're just not able to get all of those tasks accomplished to bring the party together. We know we need supplies for the party, we know we need invites, we need a guest list, we need a venue. It might be a very basic little party that you're going to have in your backyard, but it's still a certain amount of planning. You need food, you might need to bring a gift, etc. So it's a difficult time, unable to put all of that together. Confusion with time or place, unable consistently to figure out those things. Starting to have difficulty with visual images. One of the assessments that we use for patients is to have someone be able to draw a simple clock, because that's a very common visual image that people struggle with. Unable to retrace steps if you lose something. So again, you can lose it. We all lose things, but we generally can sort of step back through, okay, where was I the last time I had it? And then we can start moving on. Becoming withdrawn, that's a very common thing. People recognize in themselves something isn't right. They may not be able to define exactly what's going on, but they definitely know something isn't quite right. And so it's natural to then self-isolate. And changes in mood or personality. There's a common misconception that when you get old, you get depressed. No, absolutely not so. That is not a normal and natural part of aging. And so if those changes are coming and happening, then that's a moment or an opportunity for assessment. So again, I've commented already, Alzheimer's is the most common type or form of dementia, about 70%. There are other types of dementia, however, that as healthcare providers we need to be aware of so that we can sort out if there are any causes that may have come on board that could be reversed. And some of them I've just mentioned here. I'm not going to get into those today because we don't have a lot of time and we want to focus on what's most common. But vascular dementia is very common, and vascular refers to vessels, changes in the vessels, so cardiovascular disease, stroke, other types of things can cause vascular dementia. Lewy body dementia, that's where we see proteins deposit in parts of the cerebral spinal fluid in the brain areas, that the proteins start wiping out the dopamine. And so dopamine is a neurotransmitter that's completely depleted in Parkinson's. And that's why Lewy body dementia looks a lot like Parkinson's. And for doctors, it can be kind of hard for them to tease that out sometimes. And then a couple of other types of dementia, and I comment here on the reversible dementias because we can have sometimes a situation where a patient was started on a medication and in not too long their cognition is declining, things don't look very good, the picture is not pretty, and we can discontinue or decrease the dose, looking at what the medication is for and looking at the risk benefit. And wow, with just a change in medication, we can reverse those symptoms that the patient was experiencing. And so those are some reversible dementias. So I wanted to comment for a moment on mild cognitive impairment because we talk a lot more about this. And I think it's because we're gaining a lot more knowledge in the area of dementia. And it's important for people to understand that you don't just, as I said, it's very slow progressing. And so we don't just have dementia today, but we didn't yesterday. And so we go through this sort of arbitrary time frame of what we call mild cognitive impairment. And we know that there's this period of time where there are changes happening, but they're still able to function at home, perhaps, or maybe they need a little help with certain tasks, but other tasks they're very successful with. So it's nice that we now sort of have a term that we can use and help explain to people that, yes, this is a time that things aren't quite right and aren't quite normal, and you're understanding and experiencing and realizing that things are changing for you in your life. However, don't be frightened by the idea that all of a sudden you are unable to completely care for yourself, and so on. So that's kind of what we are referring to in terms of mild cognitive impairment. And assessments and neuropsychiatric testing helps determine if the patient truly has mild cognitive impairment. The identifying factor here that people need to be aware of is there is a much higher chance of developing dementia if the patient is determined to have mild cognitive impairment. So I'm going to give you some statistics. There will not be a quiz at the end. But Alzheimer's disease, of course, is very common. It's thought to be the 5th or 6th, there's some argument, 5th or 6th leading cause of death. There's a range in the research about a 3 to 20 year survival. I would say 10 years is probably a pretty good number. Most patients don't live to be 20 years out. Obviously, there's quite an expenditure from a healthcare standpoint. That isn't really our primary concern. Our primary concern is taking care of patients and making sure that they have the best quality of life for as long as possible. But indeed, it is something that we think about in healthcare. Risk factors, the genetic side of Alzheimer's is really where things are hot in terms of research. And there was a time when we said, well, you won't know you have research until you die, because we have to look at the brain tissue to know. And it's still considered in medical research that a definitive diagnosis is based on looking at brain tissue, but now we do have the capability to do PET scans and help people understand and learn if they have certain genetic markers that predispose them or increase the likelihood that they will develop Alzheimer's. I know of a young woman here in town, she's just in her mid-30s, and her mother died in her 60s from Alzheimer's. And so she's engaged in a clinical trial out of Philadelphia, and she actually has both of the primary genetic markers for Alzheimer's. And so her risk of developing Alzheimer's is nearly 100%. And so that has to be a little bit terrifying. And so I would pose upon you to just sort of let the thought roll around in your mind. If you could today run it, if we had a PET scanner right out here in the hallway and you could go get a PET scan and find out if you're likely to develop Alzheimer's or not, would you do that? Would you want to know? And I ask that question because of what we will talk about a little later in the conversation about our current treatments. So it can be a little bit of a daunting thought to know that you have these genetic markers. And I've commented here about if you have the ApoE4, 90% of those with the 2 copies will develop Alzheimer's disease by age 80, and it's typically before age 80 even. There are some other genetic markers that are being looked at as well. And what these genetic markers tell us is that you build the amyloid plaque in your brain sooner and faster and more, et cetera. So that's sort of what we're knowing, at least early on, about the predisposition to Alzheimer's. So again, I've talked a little bit about the family history, the genetic component there. Mild cognitive impairment puts us at higher risk for Alzheimer's disease. I've also talked about vascular disease, lifestyle and activity. People are always asking, what can I do to prevent it? There's no perfect answer to that question. We don't have any great answers. Research is ongoing, of course. The best things we know about, and I have a couple of slides about it later, but eat right. Do all the things we already know and often don't do consistently because we're human. But eat right, exercise, keep your brain awake, keep your brain alive by exercising it, by reading, by staying stimulated, by engaging socially. Those are the best things that we know how to do to help prevent cognitive decline. And that doesn't necessarily mean prevent Alzheimer's disease, but to help prevent a cognitive decline. And then there are some things that are just, they just are what they are, and we can't help them in terms of like head trauma and so on. Those things sometimes just happen, exposure to certain chemicals. But there are correlative studies that do identify some relationship there. Major brain changes, I'm not going to get in the weeds with the brain changes here because I'll have you all asleep before you've had your first cup of coffee. But I do want to say that the primary mechanisms behind Alzheimer's do sort of remain the mainstay today, despite a lot of discussion about do the two classic components, amyloid beta, which are these deposits, the neuritic plaques, and I've given you some pictures here. These are nice, healthy neurons in the brain that transmit chemical signals that help us with our communication and thoughts. And then over here is a diseased set, or Alzheimer's brain, a diseased set of neurons. And you'll see the neurofibrillary tangles right around in the middle of the neuron here. And then you'll see the plaques building up, the amyloid beta plaques building up outside the neurons. And so these tau proteins, which accumulate and junk up the neurons, so to speak. And then the amyloid beta clumps, which build up outside the neuron, those are still considered to be the two standing beliefs in terms of what causes Alzheimer's. Again, with growing research, there are thoughts that there are other mechanisms, but these are the mainstays. The point is, it's overall a loss of healthy neurons, a loss of healthy nerve cells, which are neurons, which help ourselves communicate. They help us, our brains function and have normal thought processes. And then the next slide is just a different sort of picture for you in terms of visual learners. I like to show a couple of different things that can be done. And on the right side of that slide, it will show you, again, a healthy brain, and then toward the bottom, it will show you a changed brain in terms of Alzheimer's. The overall size of the brain changes. We see the ventricles in the center part of that picture. We see those enlarge. We don't want that to happen. We see the cortex around the brain shrinking, and we don't want to see that either. So those are some main changes that we see in the brain. I did want to take note, because I'm going to talk about it just a little bit later, but in that previous slide where I showed you the picture of the healthy neurons and then the diseased neurons, I want you to envision those neurons where the picture cuts off, just a little string, just a little, one little strip coming out the bottom of that neuron, because we're going to reflect on that in a later slide in terms of how the medications work. So the clinical presentation, what does it look like? We're going to blow through these few slides because I think you already know this. And then please, if I'm going too quickly through just these few slides, just raise your hand and slow me down. That's no problem. What we are comfortable with, I think, in our society when we talk about Alzheimer's or we talk about dementia in general, we think about the cognitive changes that people experience. We think about the functional changes, but sometimes we forget about or we don't recognize the neurocognitive changes quite so much. So you can take a look at your slide there and see the obvious ones that maybe you cue into, like memory loss and unable to get things done and forget that they've done things, and so they do things more than once, etc. The neurocognitive changes that I want to sort of have you start embracing in your mind that really truly might be related to Alzheimer's are on the right-hand side of that slide. And those are the things like the mood changes, depression, sometimes even extreme mood changes like psychotic changes. Patients become very agitated potentially. They wander, they don't understand the need for whatever it is you're trying to ask them to do, and so they can become combative, uncooperative, and very repetitive in nature. So that then elicits the need for the caregiver to be kind of go with the flow, not argue with the situation, et cetera. And that yet is a whole nother presentation or conference, really. Yes, ma'am.
Do you see that kind of happen in waves? Like with my grandmother, she got really nasty, and then toward the end of her life, she was the sweetest thing ever.
You know what, if you've seen one patient with Alzheimer's, you've seen one patient with Alzheimer's. But yes, absolutely that can happen. So some patients, the agitation and irritability is worse early on, and that is thought to be because they recognize. And then as things change and they lose the ability to recognize, then it's just not a big deal anymore, and they become more pleasant and easygoing. And other patients, the neurocognitive side of things, sort of the brain chemistry and the wiring just goes a bit awry, more so later on in their cognitive decline, and so they become more agitated and more angry later on. But so you can see it in waves, and you can see it progress either way. So it doesn't surprise me that she had that happen. The next slide then, diagnosis. I've commented that, again, the definitive diagnosis is brain tissue, but clinical diagnosis is what we rely on. And this takes a lot of interviewing, patient time with the provider and the caregiver, family members, discussing what are the problems here, what's going on at home, what are you seeing, and so on. And then not only just talking and getting good history, but there are a lot of tests that can be done, neurocognitive tests, brain imaging, blood work, it's a whole gamut of testing that will be done. And in the next slide then that says dementia screening tests, this is not a comprehensive list, so I don't want you to laminate it and stick it in your bag and think, well, keep checking this, and as long as all of these are good, I don't have dementia. I don't want you to rely that heavily on it, but I do want you to recognize that there are many things that go into formulating a diagnosis of dementia. There are a lot of blood tests that can indicate problems that look like dementia but are not. Simple things, potentially simple things like vitamin B levels are severely off, or thyroid function is off, etc. So it just begs to mention that it can be so many different things happening. It might be quite reversible. The next slide, stages of decline in Alzheimer's disease. There are some common features in early, middle, and late stage Alzheimer's that I've noted for you there. Again, this is not a comprehensive list, just a guide for you to have some context for things as they change, if you know of someone or are taking care of someone, or even have some concerns about trying to decide, am I having some changes here? And so the middle ground is always the most gray. It's always difficult to know what kinds of transition you're in, but hopefully that will provide for you just some kind of idea. You know, we have some difficulty with social interactions. Things seem a little strange. She seemed off today. He didn't quite seem himself, all the way over to the inability to even carry conversation, or finally the inability to speak. So it just gives you sort of a range of things that are happening there. Moving on to the goals of therapy, there's no known cure. This is a progressive, fatal disease. What our goals are is to treat the struggles that we can treat, to offer the patient the best quality of life possible. We certainly want to treat those behavioral and psychiatric features that can sometimes creep up. We want to, if we can use medications, then let's do, but we need to recognize the limitation of medications as well. And certainly we need to focus on the team that's in charge of helping to take care of that patient. And most often, at least until very late in progression, most often the majority of that team is the family. And so we really need to focus on making sure that they're taken care of as well. So a general treatment approach in the following slide that I've commented on here is early and continuous treatment with medication until the medication's no longer effective. And then even while that medication's going on, early in treatment, we need to make sure that the patient's tolerating it well and that that's the right choice even early on. Again, treating behavioral symptoms, education, and just making sure we're keeping open lines of communication. Patients don't have just one physician anymore. We've segmented our healthcare system into specialties and subspecialties, and you might think for yourselves, do you just have a primary care provider, or do you have that person and then a cardiologist and a pulmonologist, and when you saw the cardiologist, they sent you to an electrophysiologist, and then you saw the CT surgeon and you went to the valve clinic, and so it really gets segmented. And so just really open lines of communication, making sure that everyone's talking to everyone. Thank you. You are the hero of the day. All right, so let's buzz forward to, here we are. So now I can pass the handout back. Thank you for letting me borrow that. So on to non-drug therapy. I feel like even though I'm the pharmacist, I think in my career path, specializing in older adults, I really spend my career trying to take people off of medications. I think we are an over-medicated society, and so it's important to me to make sure that we utilize medications appropriately, only for the duration they should be used, at the doses they need to be used, and when we're done with them, we should be done with them. And I think something that I try at least to relay to my students when I'm teaching them is when we're talking about disease states like Alzheimer's, we can't forget that just because the patient was diagnosed with Alzheimer's, their diabetes didn't go away, their hypertension didn't go away, their heart failure is still here, they still have osteoporosis, they might still have depression if they had it since they were 20. You know, it's now just a more complex situation. It doesn't mean everything else is gone. So really focusing on the non-drug therapy, because we know that dementia, we don't have great treatments for dementia. Non-drug therapies tend to be, they're always best, but sometimes we do implement the medications as I really consider them more as ancillary treatments. When working with the patient with dementia, it's really important to not sort of argue the case. And that's something that I have dealt with in my own personal family. My grandmother died of Alzheimer's a few years ago, but my mother, mom always knows best, right? Daughter doesn't matter her training. But my mother would sort of battle with her mother saying, no, mom, that's not what you do. You've never done it that way. You don't need to do it that way. You haven't done it, so no, you're not going to do it like that. Or, no, mom, you know that's not the way you do it. Well, and then I would say, Mom, it just doesn't do any good to argue with her. It really just agitates her. She's not capable of accomplishing those tasks in the same way because that part of her brain is gone. And so you're really just upsetting yourself because this is hard for you, and I recognize that, but you're also just upsetting her. So there's really nothing being accomplished here. But then she would look at me like, you're just the kid, you're just, you know, I'm the mom, I know better. And so those are always interesting family dynamics and very real and very important to work through. You know, my mom would put a little note by my grandmother kept a certain pill that she took in her bread box. I don't know why. People do funny things. And so then she forgot to take her pill all the time, right, as cognitive decline worsened. So my mom decided she'd write her a note and stick it to the bread box because that would help her. Well, but she didn't even know to look at the note or go buy the bread box because she'd lost that capability. And so, you know, my mom had a hard time understanding that because, of course, it's her mom. And she didn't know how to accept that those changes were happening and that she had progressed to the point that that was no longer an effective way to help her, and didn't really want to hear from anyone at that time that that was the reality of the situation. Not to mention that a note by the bread box could be detrimental because then she could see that note 8 times in a day and take that medication 8 times because it was brand new every time she saw it. So really just some intricate little things that happen that make all of the team-based approach and how we react and how we support and communicate so critical. Again, I talked a little bit earlier about exercise and other sorts of support that we can provide. This is once dementia really is known, but we do have a lot of evidence that shows that exercise can be beneficial to the dementia patient. And there are animal studies that show it will change the amount of amyloid beta built in the brain. We don't have a lot of data to show that in humans, but we have a little bit, not much. Mental stimulation, exercise does help. Exercising the mind, does help. So we have different therapies that are ongoing. Kyle certainly can speak to a lot more of these things, so I'm not going to spend a lot of time on it, but just to really emphasize the need for non-drug treatment. Ideally, we would all just carry around a box of these pills in our pockets that are called the cure for Alzheimer's. However, they don't exist. I sure wish they did. When I found this little box off the Google Images, I initially was wowed because I saw these little leaves here and I thought, oh my gosh, that looks like marijuana. And then I thought, no wonder, this is going to become very popular. We live close to Colorado. People are going to want these. But anyway, so it just would be so nice if we had something to cure the disease. And of course, that's what research is ongoing and trying to find. But to date, we do not have a cure. These, however, are the drugs that we have on the market. They do not come without risks and side effects, but we are going to spend a little time talking about them anyway. In terms of how the Federal Drug Administration has approved them, there are drugs to treat mild to moderate Alzheimer's and then those that treat more severe. in the clinical environment, when we're out practicing and using medications to give people, I don't think we really focus on that a whole lot. But sometimes when you're the family member, you want to know, well, but my mom or but my dad is actually really, really struggling right now. It's really bad. So I need something that would work for them. So we'll start moving through the drugs then. The classification of the drugs, there are 2 different families of drugs that are approved for the use in dementia, in Alzheimer's dementia specifically. And I asked you earlier I won't get too nerdy science on you here, but I asked you earlier in that far back slide to envision that neuron in the brain where it had some fingers sticking out of it. And then I asked you to envision the tail or the little strand coming off the bottom of it. And coming off the bottom of it would be a little channel of chemical happenings, if you will. And in our normal brains, in the non-cognitive challenged brain, we have a lot of chemicals exchanging pathways and having conversation, if you will, about how to make us do all the things I'm doing right now and that you're doing right now, thinking and having correlating what I'm telling you to whoever it is in your life that you're thinking about or worrying about, or maybe even concerns you might have about yourself. Well, I'll tell you, in the Alzheimer's brain, the picture is a little different. And so we need to increase the amount of a chemical called acetylcholine in the Alzheimer's brain. And so when this chemical transaction takes place at the end of that little tail on the neuron, the healthy neurons, because we know in Alzheimer's a bunch of those neurons are dying. So in the healthy neurons, we have to take a drug to help in this healthy exchange where acetylcholine is being dissolved and broken down. We have to give people a drug, or we don't have to, but we do give people a drug that helps preserve and block a chemical transaction from happening to break that acetylcholine down. And so what happens then is that drug goes in there, it blocks that chemical reaction from happening, and it allows acetylcholine to build and flow freely within the chemical space in our brain. And with building up that acetylcholine, it helps improve our thoughts and our functions to a better degree than without the drug in terms of that cognitive decline. Because we already have less functioning neurons than we did. So with what good functioning neurons we have, we need to flood the amount of acetylcholine in there so that we can have the best amount of functioning possible. So this side is the class of drugs called the cholinesterase inhibitors, okay? And we'll come back to this picture again in a moment. As with all drugs, anything that you swallow comes with a pack of risks. And this class of drugs, the bummer is that they can cause side effects like nausea, vomiting, stomach upset, loss of appetite, insomnia, dizziness. So all the really good things that you hear on the commercials about every drug, I suppose. And then slowed heart rate, which can be another problem as well. So in this population of patients, we often struggle with them having an appetite anyway or remembering to eat. And so now we've just introduced a drug that might affect that, not only the remembering to eat or having an appetite, but then we've now caused something that might upset their stomach to the point that they may not want to eat. So it can be very problematic in this population of patients. Slowed heart rate is of particular concern to me because when we slow the heart rate, it changes the ability to accommodate. When you go from a sitting to a standing position, you get more dizziness, and then you fall down and you break a hip, and then we have a whole nother host of problems. So definitely problematic with these medications. The first, the hallmark, the gold standard in this class of medications is called Aricept. Most of you have probably heard about that. The generic name is donepezil. It's been on the market for a long time. We have a lot of data regarding its use. Because I'm a pharmacist, I don't feel like it would be right to give you a drug without the dose of it. The dose may not mean much to you other than that we most commonly see people on about 10 milligrams a day. Often we'll start people on 5 to make sure their tummies can handle it, that they don't have any problems with it. And there is a newer formulation of 23 milligrams out on the market, which was really just the pharmaceutical companies putting that out because the 10 milligram was going generic, so they needed a way to try to keep their pockets full. It really is the best tolerated agent in the class of drugs, We see most people do best on this one as opposed to the couple of others that are available. The next one is rivastigmine or Exelon. It initially came out in a pill form, and more recently in the last maybe 10-ish years has come out in a patch. So that's a beautiful benefit to using this medication. If you have someone that has swallowing difficulties or is very agitated and just will not take pills. There are some people that just will not. So it's nice to have an option for a patch. I've noted for you here areas that the drug can be placed. And I note that because with Alzheimer's patients, they can be little pickers and things bug them easily. And so that you need sometimes to be very strategic about where you place the patch.
So Aricept has a patch too now.
They just came out with it. We don't know a whole lot about how well we know that the absorption works in terms of FDA approval, but we don't know how well patients are tolerating it all that much yet. So, and it's incredibly expensive, which I was going to get to here in just a minute, but thank you very much for bringing that up, because it is good for those people that can't swallow, or won't. I should say won't, because it's more common that they won't.
Well, and I thought too that perhaps it might be better because it's time release, so the side effects may not be as...
Yeah, anytime you have a patch, it will be a released mechanism in terms of how the dose is delivered. It has to be released over time, and because that's the purpose for giving a patch. So yes, sometimes you will have less side effects. I will say the data does show with both the Aricept patch and the rivastigmine patch that we aren't seeing significantly less side effects. So, time will tell, anecdotally, time will tell if patients do better on it. But the science behind it doesn't show that it's a lot better tolerated. So.
And not necessarily more effect, we don't know the effectiveness yet.
Correct. Yeah, it'll take some time, some post-marketing studies.
Okay.
Yeah. And the third and final one is galantamine or Razidine. And this is one that we don't use a lot. It used to be twice a day. Now it's once a day, which is nice. Again, that sort of slow release. And this one has to be taken with food. There are some cautions with kidney and liver function. So again, it's not quite as ideal, but it is an option for people that can't tolerate the other medications. So that's why we, almost in all classes of drugs, it's why there are alternatives, because all of our bodies are different and we tolerate things in a different way. So important points that I wanted to give to you in terms of this whole class of medications. As we increase the dose, we're going to increase the amount of acetylcholine in that space in the brain that I showed you, that postsynaptic space in the brain. With that comes the increase in side effects for most people. So more isn't always better, is the home run point from that. Switching between agents is not recommended. We know that these drugs do not cure the disease. We know that they do not halt progression. We know they can slow progression. The thing is that if mom's doing okay on Aricept, boy, I don't know, she might do a lot better on Exelon. Well, the trouble is that if you switch her and she didn't do better on Exelon, you've lost what you had gained with the Aricept. And that we do know with clinical studies. And so it's better to just leave well enough alone if mom or dad, whatever, is tolerating it. That we definitely know. We call that kind of the cognition clock, and we don't want to lose time on the cognition clock. So that's an important component to not just switching things up. Might do better here, might do better there. Let's try this. We haven't tried that yet. There are some diseases we do use that approach to, but definitely not for Alzheimer's. The second class of drugs that we use to, yes?
You also said that interruptions over 3 weeks?
Yeah, there's a little bit.
Like every 3 days?
Yeah, so we have that window of up to 3 weeks because that's sort of the time frame by which you may start to see decline again. So if someone's just been sick for 10 days, they've had pneumonia, and they're just not taking that medication, or maybe they were admitted to the hospital and the hospital didn't give them their Aricept while they're there, families shouldn't panic because they didn't get their Aricept for 10 days. Something, does that help? Okay.
Very practical.
Yeah.
And it happens all the time.
You bet it does. You bet it does. So Namenda is the medication in the second class of drugs. It's the only medication that we have in this class, memantine. It is a drug that works. Let's see, I forgot to put that picture again in that slide. But on this side of this picture is how Namenda works. And it's actually working on the calcium channels and sodium channels, and it gets very chemistry-like. But what we're doing basically is a similar reaction to help deal with glutamate, which is a different, pardon me here while I quickly go back. We're trying to block the transition of glutamate in that extracellular space, because glutamate is an excitatory neuron that we feel can worsen dementia. And so what we're trying to do is block that receptor that then can help preserve the neuron, keep it healthier for longer. So that's the idea of why we give Namenda. So they do work in different ways, and we often use them together since they work in different ways. Side effects here, very similar, very similar. Patients complain a lot about dizziness on this medication, confusion, which is sort of the opposite of what we're going for, so that can be limiting. I will switch gears just a little bit in terms of not talking about how the drug works, but yet when to use the drug. And that's kind of the million-dollar question. It's a little bit different for everyone. And I comment here on when to start therapy. I think the key is probably as early as possible, and that early as possible is only when it's right for everyone in your group, your cohort of family and physician and patient and so on. But we do know that the earlier that they're started, the more benefit is seen from having used it. So that can be helpful. The things that we're looking at in terms of the benefit from the medication, oh gosh, I better speed up, I'm running out of time here, are things like quality of life, treatment goals, potential benefit, and side effects. We're always wanting to look at that. On the flip side, when do you stop? That's a tough time. That's a tough decision-making process, and everyone is very sensitive to that in my area of practice. We typically want to stop when quality of life is poor, when the dementia is progressing to the point that we just don't see improvement anymore. The medications definitely have side effects. There's no sense in keeping people on medications that are having side effects, and that's at any stage of the game, really. If you've had a patient on medications and you're not seeing any improvement whatsoever, and then when slowing the disease is just no longer a goal, and that's toward end stage. So I did want to comment on what we call behavioral and psychological symptoms of dementia. And this is when I referred earlier to in the slides about how we think about people losing their memories and so on, but we may not always think about those depressive or psychiatric sort of problems that come about. And so I've listed some of those here for you. How do we treat those? Again, Kyle's expertise is in this area, so I'm not going to speak on anything except the medications for the sake of time. But I do want to say it's an area of medicine that we've overused medications and see small benefit. So there's a need for education to medicate less in this area. Antipsychotics are the medications that have been used a great deal to treat some of the psychotic symptoms, and there's just no good reason to use them unless absolutely necessary. There are times when a very small dose can be beneficial. But what we have seen with using these medications and watching people over years is there have been more deaths from using these medications in the elderly because of cardiovascular events and cerebrovascular events related to the use of these drugs in older adults with dementia. So it's really best if we can avoid them altogether. Mm-hmm.
So do people that have a dementia diagnosis and have psychotic features, are they related to the dementia, or is it something different?
Almost always they are.
It's related to the dementia.
Yeah, it's related to the dementia, unless they have a long-standing history of a psychiatric disorder. I will say those are tough things to tease out sometimes. I will also say that if someone has had a very strong lifelong history of severe mental illness, and I'm talking about like paranoid schizophrenia, borderline personality disorder, and so on, I don't want to sound morbid, but I'm going to sound real, and that is that most of those people do not live long enough to develop Alzheimer's. That's just the reality. So what are the drugs that I'm talking about then when I mention antipsychotics? You see these on TV, so that's why I mention the names. Things like Seroquel, Risperdal, Zyprexa. We use them for a lot of things in our adult population, and that's good, and they're safe for that, and that's fine. But we are specifically talking about this population of people. Depression does occur in about 50% of people with Alzheimer's, but sometimes it's hard to tease out if we're just not getting the diagnosis quite right, because it's very difficult to do. There are some antidepressants that can be used to benefit those mood changes in older adults, and some of them work better in this specific population than others. So that's a conversation that you definitely want to have with the prescriber. Maybe if you are taking an antidepressant at 50 and it works great and it has saved your life, that may not be the right antidepressant for your father who's having depressive symptoms associated with Alzheimer's. So just to keep those kinds of things in mind. Other considerations, as I've talked about earlier, just because you develop a diagnosis of Alzheimer's doesn't mean all of your other problems go away. So we need to pay attention to that, and that's when a pharmacist can be very beneficial, because we have then a whole laundry list of medications, and we can start looking at what are the benefits to these medications, what are the risks, what are the most important, what problems can we solve here, and prioritize and find out if any medications are working against each other. So for just the last minute or two, because I often feel like I present on Alzheimer's and dementia a lot, and I feel like Debbie Downer sometimes, because I'm presenting on a disease that's a very sad disease. It's crippling to families. It's very sad. And then I move on to say, and here are the medications that don't work great. So I feel like I often just am the bearer of bad news. But I always like to try to finish up with, is there any hope? Do we have anything good going on? And I want to say yes, indeed. There is research going on, and there are many people devoting their lives to the area of research in Alzheimer's, and it is a wonderful place to be in terms of research, and it's invigorating to go to conferences and identify and talk to people that are working in this area of research. And I wanted to share with you a couple of websites that if you're interested in the area, you can go on. And even if you're not a scientist yourself, the language is printed in a way that is very understandable, which is nice. So the NIA, National Institute of Aging, offers a lot of information about different Alzheimer's and related dementia research, also just different information for you as well that's very trustworthy and comprehensive. Within that website, you can click on one of the links, and these are all provided for you in the slides, where you can learn about clinical trials that are ongoing. You can look at the states. You can search it by state. You can search it by type of dementia. Lots of different ways you can search and find out what's going on in the world of Alzheimer's research. And if you have an interest to get involved, there are opportunities for that as well. And within that website, you can maneuver a way around and identify volunteering opportunities as well. It's really critical. It sounds a little bit sort of like a large undertaking, I think, to want to get involved in something like that, but really that's how cures are found, is people just allowing themselves to be observed. And it doesn't necessarily mean you have to do anything invasive or dangerous or frightening, but perhaps just be observed. That's how we make a difference. Finally, I've offered for you a few resources that are highly reputable and trustworthy. I think, Dr. Google sometimes is a little dangerous. And so here are some nice resources for you. So in the last few seconds or a minute, I don't know how much time. I usually am racing to beat the clock, but at any rate, I would be happy to take any questions. Yes, sir.
My mother-in-law experienced many of these dementia/Alzheimer's characteristics through Parkinson's. It affected her mentally very severely. Well, my wife and I would like to get, this is 15 years or so back, 20 years maybe. My wife and I would like to get information as to how she was cared for, what her symptoms were, because we weren't there full time when she was under care. Her husband, my father-in-law, was alive, but he was not really able to, gather data. And we would like to But we've been told, we haven't really tried, but we've been told that her medical records during her time in a nursing home, for example, a hospitalization, were not available to us. And is that so? And is there any way that we could get around that?
Yeah, so that's a great question, and it's about 15 years ago, you said?
Yeah.
Yeah.
I'm trying to count back. Yeah, it had to be about between 15 and 20 years.
Yeah, so it is certainly possible that that long of a time ago, her medical records are not accessible. Every state has different laws in terms of how long an institution, facility, hospital, doctor's clinic, nursing home is required to hang on to medical records. And after that time, then they are allowed to destroy them. And many states, that's 7 years, 10 years, but just from immediate recollection, I don't know of anywhere that has to keep them beyond the 10-year mark.
If they did happen to have them.
If they did happen to have them, I don't know, again, in good faith, people would try to give you the records, just generally speaking. In good faith, people don't try to restrict that information. So I really feel that probably if you're getting a pushback or a denial of access, it's because they truly are not physically available. Working in healthcare, I feel like we try very hard to give people that information because knowledge is power. You know, you can help yourself by having had that information. So I would anticipate it's truly because they've been destroyed.
Of course, is to
You bet.
Find out anything that might be relevant to our own situation,
Sure.
our daughters, you know,
Absolutely.
family history kind of thing. What
Absolutely.
kind of treatments, what kind of meds did you get?
Sure, yeah. So I'm sorry that's happened, but the time might be against you. Yes, ma'am.
Any comments on CC ads for natural supplements?
Mhm.
to improve memory?
Yeah, thank you for bringing up natural supplements for just the time issues today. We didn't have time to go into that. But I will say that it's a bleaker story than what I would like to present, and a lot of that is just funding for studies. There aren't a lot of studies that have gone on. I have patients that bring in hordes of supplements because they're trying to preserve their cognitive health. And my approach always is what has the potential to be harmful, as opposed to I can't promise you it will be beneficial, but I'm just concerned about what has the potential to be harmful. And truthfully, very little has the potential to be harmful, but not a lot has been shown truly to be helpful. Because if it did, that's what everybody would be using.
So would you put Prevacent? I think it's Prevacent, the one that they're advertising.
Prevagen.
Prevagen.
Yes, that one is quite irritating to me because it's so incredibly expensive and there's just no data to support its benefit.
With Alzheimer's, do you see changes in sleep-wake cycles with patients?
Absolutely. And that's so hard because once you've disrupted the sleep-wake cycle, then that really is like a powder keg for the behavioral problems to rise up. So, yeah.
So do you see that drugs like even melatonin or Tylenol PM are helpful, or do they hinder?
Excellent question. So are drugs like melatonin and Tylenol PM helpful? So those are very opposite ends of the spectrum in terms of possibilities. Melatonin, sure. Try it, recommend it. What that does is kind of help reset the circadian rhythm, and so that can be very helpful. Tylenol PM, one of the most dangerous drugs for an older adult to use because there's Benadryl in it. And Benadryl has anticholinergic side effects. And anticholinergic is a great big word for the side effects of no see, no pee, no poop, no sweat. Okay? And so when you cause those side effects in an elderly person, you cause them a lot of problems, a lot more than the average healthy adult. And the biggest problem that comes from those side effects I just mentioned is a fall. And Benadryl is long-acting, that's why it works so well. And so people have next day drowsiness and hangover effect that they don't even realize they have. They think they're feeling fine, they think they're cognitively intact, but boom, they trip and fall over something, broken hip, slippery slope, 20% death rate in the first year of a hip fracture. So that, I call Tylenol PM the devil's drug. I don't want anyone on that drug when they're, past about 70, unless they are a very youthful 70, and then we're going to have a real healthy conversation about it. Thank you for bringing that up. Critical point. Anything else? Yes, ma'am.
It seems like it's said that it's better to start the medication early,
Yes.
and yet you don't want to over-medicate, so I'm
Sure.
kind of lost in where.
Sure, no, that's great. Thank you for clarifying that. So I think my comment about not wanting to over-medicate is more of an umbrella statement, just in general, that our culture over-medicates, that I think we try to throw drugs at people because we don't really know what else to do for them all the time. So that's more of just a general statement.
Would you say it's good to medicate?
So I would, in terms of Alzheimer's, in terms of memory loss and using the drugs that are available, I tell people they are welcome to try them even during times of mild cognitive impairment. Okay? And then you can just stay on them until you don't want to stay on them anymore. Cost was brought up. Part of the reason why Aricept is so wonderful is that it's finally generic and it's finally affordable for people. I mean, people were losing their hats on the cost of these drugs and not getting a lot of benefit. That conversation has a little bit gone by the wayside now that Aricept has gone generic and people can afford to take it. But Exelon and rivastigmine, or Exelon and Razidine, are still very expensive, several $100s a month. So, yes, ma'am.
So I just have a quick question. This might actually apply to Dr. Carl Page at some point. I've been reading a lot of good studies about using lights, especially
Yes.
in elder care facilities and even at home when there's clients that are having a special, hard time sleeping. And because of the scope that you have in terms of touching the community and seeing what's going on, are you seeing that this is working? Are you seeing that this is starting to be used and recognized?
Yeah, I think I will defer that to Dr. Page because that's more of the non-pharm. Is that okay?
Oh, that's fine.
Plus, I think that I'm getting kicked out of here. So, but yes, I think we're seeing more and more about light therapy and other types of things like that. Thank you, everyone. I appreciate your time.
Yeah, thank you so much, Dr. Woods.